sinusitis. That's when the exit of the sinuses are blocked and secretions accumulate, and bacteria or viruses or fungus hang around there and grow and cause problems. So acute sinusitis is usually from an upper respiratory infection, allergies, swimming, or from dental manipulation.
Whoa, who knew?
Yeah. Chronic infections associated with chronic infections associated with this. Hold on.
You can get chronic sinusitis.
Okay, if you have chronic sinusitis, along with allergies or nasal polyps, it can result in irreversible loss of normal ciliated lining of your sinus cavity. There we go. As Ashley is aspirating on her,
like, legitimately that time, not just kidding.
On her vitamin water again.
It's not even vitamin water, it's Crystal Light.
So, sinus symptoms of sinusitis include pain to the affected sinus, headache, purulent drainage, purulent nasal drainage, congestion, fever, and malaise. And you can actually illuminate their sinuses. If you turn the light out, hold your pen light up to their sinuses like this. If this was a pen light, if you held it up here and held it up here, the sides that was clogged up and backed up
wouldn't illuminate.
Right, it wouldn't illuminate.
Their face should light up like a jack-o'-lantern.
Yeah, and if it doesn't, they could have a
sinus infection or sinusitis.
Yeah,
you can also illuminate breast implants.
Yeah. So
we learned that from Miss Data.
Find a friend. Check out her boobies. Acute infections should be treated with antibiotics for 10 to 14 days, and you can use decongestants, nasal corticosteroids, mucolytics, and second-generation antihistamines. Those are the ones like Allegra, Clarinex, those kind of stuff. They don't cause as much drowsiness. Anyways, chronic infections need to be treated with 4 to 6 weeks worth of antibiotics. And you can also try nasal cleansing, which is like a neti pot. Those are pretty cool.
I like to call it nose deep because that's what it is.
It is. Yeah, you have to hang over a sink or somewhere, and
saline.
It's like saline, and you squirt it up your nose, and it goes up and rinses through and comes out the other side.
It's really good for you.
It is, and it feels a little bit weird, but once
helpful.
You get used to it, it can be nice. But if you're going to recommend that, don't recommend that to somebody who has inflammation, because they won't be able to get through, and it could back up in their ears and stuff.
You can't use it if your nasal passages are totally blocked.
Right.
If they're totally blocked,
you have to wait.
Do it.
Yeah. They may need a nasal endoscopy for relief of chronic sinusitis. And I'll throw polyps in here because I talked about them for a second.
Okay.
Polyps are benign mucous membrane masses that form in response to repeated inflammation, and they cause grape-like projections. They can obstruct your nasal passageway and lead to a lot of discharge, speech disorientation, and chronic sinusitis. Steroids may slow the growth, but if you have really bad nasal polyps, you probably end up getting surgery. And they can reduce them, cauterize them off, and make it all better for you. Yeah. Well, head and neck cancer, this is random but thrown in there. Head and neck cancer, usually squamous cell. That's about all you need to know for that.
It's usually squamous cell.
Yeah. And Ashley's going to talk about some pharyngitis real quick.
All right. Pharyngitis. Acute inflammation of pharynx, tonsils, palate, and uvula. 70% of cases are viral. 15 to 20% are bacterial.
Strep.
Nobody knows which the 10% are.
Strep is the most common bacterial pharyngitis infection.
I'm also going to talk about tracheostomies because they're not in here, and we wrote them in breakfast. If you have a patient with a tracheostomy, which is an artificial opening into their trachea to bypass the upper airways, if it comes out, you're going to want to try and replace it
with an obturator. You should always keep one of those at the bedside. It's just a little piece that is curved, and it just helps you shove things back where they belong. Yeah.
If you can't get it back in, you're going to want to cover it with a sterile
gauze. Yeah, and then call the doctor.
Call the doctor.
And you want to assess their respiratory status. If they're if they're able to breathe on their own and doing okay, you would call the doctor. If not, you would probably need to call the rapid response team or like a code or something.
Maybe a code.
If they can't breathe at all without their
trachea. The physician does the first dressing change after a tracheostomy has been placed. Not you. There's a test where you can you have them like swallow some blue dye and see if it comes back in their sputum. If it does, that means they're aspirating. I don't really remember why you did that. But
check to see if they're aspirating.
Check to see if they're aspirating.
Yeah.
Okay.
Because they need to have their the cuff. There's a cuff inside the.
Right. There's a cuff inside the tracheostomy. You can, if they have a cuff, they can't talk.
If the cuff is inflated, they can't talk.
So if you were going to deflate the cuff so that they would be able to talk, you need to use that blue dye test to make sure that they're able to control
to make sure they're not going to aspirate.
Make sure they're not going to aspirate, yeah. So cuff inflated, not talking. If you're going to deflate, you check their ability to swallow. While you're changing the ties on the dressing, you leave the old ones on while putting on the new.
That keeps it becoming dislodged.
Yeah. I guess we'll go ahead and throw in bronchitis. Bronchitis is viral. It's usually the rhinovirus or influenza. That's strange. Or bacterial. Could be Streptococcus pneumonia, H. influenza in smokers, or Mycoplasma pneumonia in non-smokers. Symptoms are a persistent cough that follows an upper respiratory infection. So you've already had the cold and now it's worse and it's developed into something else. You have clear mucoid productive cough, so you're coughing up clear things. Fever, headache, malaise, and shortness of breath on exertion. The treatment is fluids, rest, and anti-inflammatory agents, cough suppressants, bronchodilators. Antibiotics are generally not prescribed unless you have a prolonged infection or you're a smoker or you have COPD.
The main treatment for that, though, is the bronchodilator, just like an inhaler.
Yep. They will give you an inhaler, some Tessalon pills, and send you on your way.
Yes. We'll talk about pulmonary fungal infections. Yay. They're most frequently seen with people that are seriously ill, or those that have been using steroids, antineoplastics, and immunosuppressants, or on multiple antibiotics for another reason. You see it in AIDS and cystic fibrosis patients. It's not transmitted from person to person, so it would not need to be in isolation. And the signs are similar to bacterial pneumonia. It's just fungal instead. You treat it with amphotericin B. Out of all that, that's probably the one thing you would need to know. And you would give it every other day for 4 to 12 weeks. Wow, long time. Amphotericin has a lot of side effects, and I don't know what they are, though. Sorry about that.
It has a lot of side effects.
But to decrease the side effects, you want to treat prophylactically with an anti-inflammatory 1 hour before giving the amphotericin. So that sounds really familiar. It could have previously been on something that we might have taken.
So before administering amphotericin, you might want to give this prophylactic anti-inflammatories.
Yes. Bronchiectasis is permanent abnormal dilation of one or more of large bronchi that result in the destruction of the elastic and muscular structures of the bronchi wall.
All right.
Yeah, cool. Signs and symptoms of bronchiectasis include copious purulent sputum, short of breath on exertion, fatigue, weight loss, anorexia, fetid breath, which is that fruity, acetone breath, crackles, bronchi wheezing, and advanced stages they would have general malaise, clubbing of the fingers, and cor pulmonale. A chest X-ray would show strategic infiltrates, and you would treat with antibiotics based on the organism, and you might actually need nebulized antibiotics to help it actually get into the lungs. Bronchodilators for the bronchospasm, mucolytic agents, and expectorants. You chest PT with postural drainage, flutter mucus clearing device, the PEEP, the positive index respiratory pressure, and good hydration. They need at least 3 liters of fluid a day to assist with expectorating all that fluid. Avoid smoking and other irritants. They would be a good candidate for the pneumonia and influenza vaccines because they're at high risk. And they might need surgical resectioning of the affected parts or a transplant. Ah, yeah. Sasha's going to talk about some lung abscesses because she loves those.
Great. I really don't like abscesses or scissors that much. I'm trying to get over it though. Lung abscesses. Pus-containing lesions of the lung parenchyma. Yeah. Typically caused by aspiration, but also from lung infarct, malignant growth, and tuberculosis. Fibrous tissue forms around the abscess to wall off the infection, so they just have like a little bog of infection in their body. Signs and symptoms could be a productive cough, of foul smelling and tasting, purulent sputum, hemoptysis, which is coughing up blood, fever, chills, prostration, which
I don't know.
prostration would just be like if you like really couldn't get up because you were so tired, I guess. Pain, dyspnea, and weight loss. They often have oral infections, and the abscess can spread. I'll go ahead and talk about pneumoconiosis while we're here. And that's the abnormal condition of dust in the lungs, like
you see
black
with the dust bowl.
in the dust bowl,
Asbestos, yes. Bad.
It's the general term used for infiltration and retention of inhaled particles. And now, Chris is going to talk about chest trauma and thoracic injuries, but not before I make a joke. Chest wounds suck. They suck.
For real.
For real. Sucking chest wounds. Right.
So some signs and symptoms of somebody with a chest trauma or thoracic injury would be dyspnea and respiratory distress. What a shocker. They could have a cough with or without hemoptysis, cyanosis of the mouth, face, nail beds, membranes, wherever. Big ones here, tracheal deviation, often seen with tension pneumothorax.
You want your trachea should be line. If it's over here, bad news bears.
Yes, you would suspect the tension pneumothorax. Audible air escaping from a chest wound, also a sign of a tension pneumothorax. And yes, and one more sign of a tension pneumothorax would be decreased breath sounds on the site of the injury. You might also see decreased O2 stats. Duh. Frothy, bloody secretions. They could have cardiovascular problems because things aren't working right. There might be some like outward signs of trauma like bruising. What's the pneumothorax again?
I don't think we said.
Okay. Pneumothorax is an air in the pleural space, causing the lung not to expand,
but to collapse.
Right.
Okay. I just couldn't remember if we said anything, and I know I always get a little confused. So
right. It can cause the lung just not to expand, so it just like can't go anywhere. Or if it is the tension build that can cause it to collapse.
You can collapse the lung.
Yeah. So yeah.